Hi, I'm Mary Tinetti, Chief of Geriatrics at Yale. I'm here with Anand Nayak, Chief of Geriatrics at Baylor College of Medicine, and Claire Davenport, a geriatrician at Mount Sinai Medical Center in New York City. We are part of the team that developed Patient Priorities Care, which involves aligning decisions and care with the health priorities of older adults with multiple chronic conditions. Hopefully you've completed the introduction to Patient Priorities Care. If you haven't, you may want to take a quick look at those slides. We are driving right in Patient Priorities line decision making here, assuming that you have some familiarity with the problems Patient Priorities Care addresses and who it's best for. If you haven't gone through the Patient Priorities Care Facilitator slides, the introduction also gives a brief explanation of how patients' priorities are identified and what information is obtained. We'll talk today about how to translate patients' priorities into healthcare decisions. We present a few strategies and offer some tips and scripts on how to make decisions and how to communicate with patients with multiple chronic conditions around their priorities. We then discuss how to address common challenges you may face in implementing Patient Priorities Care. Portions of this presentation are interactive. You will get most out of this training by trying your own decision making when prompted. Don't worry, there aren't any right or wrong answers. There is a lot here, so you may want to break this into a few sessions.
There are 3 steps to patient priorities care: identify, decide, and align. These steps involve everyone: the patient, their caregivers, clinicians, and the entire healthcare team. Patient priorities care begins with helping patients identify their health priorities. By health priorities, we mean the patient's health outcome goals and care preferences. Health outcome goals are the things patients most want to do in their life and that they want their healthcare to help them with, given their preferences for the healthcare they are willing and able to do, including such things as healthcare tasks, medications, procedures, self-management activities, and healthcare visits. These health priorities are then transmitted to all members of the healthcare team. The team then decides with patients and their caregivers to stop the care that may be harmful or doesn't help them achieve their priorities, and to continue or to start care that does help. It's not just about getting rid of care, it's about realigning care. The most challenging part is aligning all of those individual pieces: what the care coordinator does, what the primary and specialty clinicians do, what everyone does, into care that is doable for the patient and caregiver and is focused on each patient's priorities. And because things change, it's an ongoing process. We will explain how to do each of these steps in the Health Priorities Facilitator and Clinician training slides, but for now we want to give you an idea about what happens in aligning care with patients' health priorities and to show you that it does work. So now we're going to talk about what happens for a patient who you identify as someone who would benefit from patient priorities care in your clinic. We will go through several encounters with Mrs. B, and together we will explore how to align her care to help her to achieve her priorities. Mrs. B is a 75-year-old. Her story is typical for an older adult with multiple chronic conditions. She has atrial fibrillation, diabetes, depression, gastroesophageal reflux disease, a few hospitalizations for a GI bleed, heart failure with reduced ejection fraction, hypertension, sleep apnea, osteoarthritis, and osteoporosis. She sees a number of specialists in addition to you. Often her main complaint during these visits include a combination of fatigue, dyspnea, pain, and urinary frequency. Recently, she's been bothered by some aspects of her health care. She has hand arthritis and was taking NSAIDs that produced an upper GI bleed, for which she was hospitalized for a few days. She also takes a diuretic for her heart failure, but it's caused some increasing urinary frequency and maybe even some incontinence, which is upsetting to her. Attempts to decrease her diuretic led to some worsening dyspnea. You aren't really sure what she is taking, as she is reluctant now to let you know. Mrs. B's case exemplifies the complexity of decision-making with multiple conditions. Her clinicians are faced with uncertainty about her care, uncertainty that arises because of the balancing of competing conditions. In her case, Mrs. B's treatment for one condition, her heart failure, exacerbates another condition, her incontinence or urinary frequency. Her treatments that help one condition might cause potential harm or may be more burdensome, such as an NSAID producing a GI bleed. Given the general frustration and not sure how best to approach her care given the recent adverse events, Mrs. B's primary clinician, Dr. T, asked one of the nurses to identify her priorities. This nurse has been trained in patient priorities care identification. A patient's priorities can be identified by any number of health professionals, such as a medical assistant, a nurse, an APRN, a care coordinator, a social worker, or a physician. We also have an online self-directed website where patients and their family members can do this on their own and bring in their completed priorities template. This slide gives an overview of the process used to identify a patient's priorities. A member of the healthcare team identifies patients' priorities during a brief encounter. The priorities are then recorded in the electronic health record and include information that is reliable, specific, and actionable enough for you to use in your encounters and to help you make healthcare decisions. Here is a template from Mrs. B's session to identify her health priorities. Ideally, this template is made available in your patient's electronic health record to review during your visit. It includes what matters most, the patient's values that reflect what is important in life that don't tend to change over time. Next are health outcome goals. These are the things that are specific, realistic, and actionable and linked to what is most meaningful to them. This is what they would like to achieve in their life. The template provides healthcare preferences, which includes both things such as self-management tasks, healthcare visits, test procedures, and medications that they find valuable and helpful and that they're willing and able to do as well. And also things such as self-management tasks, visits, tests, and medications that they find burdensome, too difficult, or not helpful. These are useful to know because it may be the reason for non-adherence and may identify care that can be changed. In the final step, the patient identifies the one thing, a health problem, symptom, or other item that they most want to focus on initially because it's interfering with their health outcome goals. The one thing helps you and the patient get started in aligning care with their priorities. Let's review what Mrs. B said, and then we'll discuss how this information can streamline your decision-making for medically complex patients. In Mrs. B's case, she has two specific, measurable, meaningful health outcome goals. One, she wants to be able to watch her grandchildren after school for about 2 or 3 times a week. 2, she wants to be able to volunteer at a library 2 times weekly and to be able to handle the books while at the library. You can begin to see how these health outcome goals can inform your medical thinking and decisions. The interplay among a number of her chronic conditions are likely affecting her ability to achieve these goals. To be active with her grandchildren 2 to 3 times a week, she needs several hours without getting short of breath or fatigued. To work in the library, she needs to be able to hold books without having pain and have enough endurance to walk around and reshelve the books. First, you should consider which of her conditions might be affecting the abilities she needs to achieve her goals. Then start thinking about her current care, which might be helping or hurting these abilities. It gets a bit more complicated because it has some healthcare preferences that need to be considered. She's willing to do some things like exercise, physical therapy, and to some extent, laboratory tests and imaging. She's willing to do some medications if they're tolerable or helpful, but she's on a lot of medications and some of them are causing trouble. She doesn't really want to take all these medications. She also hates her CPAP machine and probably avoids it a lot of the time. She wants to stay out of the hospital as much as possible. As you can see, her main complaint is her fatigue. The one thing that's important to her that she wants you to focus on is to be less tired so that she can watch her grandchildren. With this information, it's time to start thinking about caring for patients like Mrs. B. It helps if you pause and try answering the following questions. Try writing them down. Remember, there aren't any right answers. First, what challenges do you face when taking care of patients like Mrs. B? Next, how might you make decisions that are consistent with Mrs. B's priorities? And third, what trade-offs arise when aligning care with Mrs. B's priorities? The next slides, we are going to discuss these trade-offs and considerations. And then we're going to try to identify some strategies to help us partner with Mrs. B to help her achieve her health outcome goals. Let's review some challenges in aligning decisions with the patient's healthcare priorities. The first is uncertainty, which we talked about in the introduction to patient priorities care. There's uncertainty about which conditions are most affecting what matters to Mrs. B and about what is the right treatment for her offending conditions. In persons with multiple conditions, there's always uncertainty of benefits and harms of individual treatments given competing conditions. There is often no right or best option. And often we are left wondering where to start given these complexities. Another challenge comes from having different perspectives among patients, caregivers, and clinicians. Or it may be that the patient and the family member together have a different perspective than the clinician. A common situation occurs when the patient is focused on how they're doing today and the clinician is focused on preventing future bad events. An older adult with multiple chronic conditions might come in with concerns about a bothersome symptom they want taken care of. For example, he might say, "I'm getting too dizzy from this blood pressure medicine. That's the most important thing for me." The clinician is appropriately concerned about adverse events related to poorly managed hypertension, such as stroke or heart failure. So the clinician is concerned about longer-term outcomes that the treatment may prevent, but the patient is bothered by something that's much more immediate. There's a trade-off that exists here. What do we do next? Differing perspectives among clinicians can also be a challenge. This may occur between the primary clinician and a specialist, or between two specialists who are focused on their specific disease. Clinicians may vary in how and whether current evidence or guidelines apply to a specific patient. How do you broach these differences in perspective, which may lead to conflicting recommendations to the patient? A clinician may differ on which conditions to focus on or which outcomes to target. The cardiologist's job, for example, is to worry about a heart attack or a stroke, and they are focused on getting the blood pressure down. Another clinician realizes that raising the antihypertensive dose is causing fatigue and dizziness, and is worried about a fall or even a hip fracture. Let's talk about what to do in these and other challenging situations in the care of older adults with multiple chronic conditions. In our work with many patients and clinicians, we've come up with strategies. These are strategies for aligning decisions with patients' health priorities and addressing some of the key challenges. We will describe the strategies, give you our rationale for why we think they are helpful, and give you examples for using the strategies in decision-making with Mrs. B. will then give you a chance to practice them as well. These are the three main strategies that have come out of our work with clinicians and patients over the past 5 years, as well as our own clinical experience caring for older adults for decades. These are certainly not the only ways to translate patients' priorities into care, but they have proven feasible, practical, and helpful, so we consider them a good foundation for getting started. The three strategies are: Strategy 1, use patients' priorities as a focus of communication and decision-making. Strategy 2, use serial trials to determine optimal interventions based on patients' priorities. And Strategy 3, align decision-making among clinicians with priorities when different perspectives or recommendations exist. These strategies are probably very obvious to you. You probably do some of them some of the time. We're suggesting you use them more consistently and perhaps systematically. Let us know if you come up with other or even better strategies. This is a work in progress. The strategies help with communication and decision-making. We transform a statement like, "You need to take this diuretic so you can stay out of the hospital or to keep your heart failure under control," to a statement such as, "I really think that this diuretic, even if it's what's causing you problems such as urinating more often, is really what's going to help you to do what's most important to you as you've described, which is being able to take care of your grandchildren." We focus the decision-making and conversation on the priorities, not just the diseases. This process may take several trials. We may not be sure what works best, but we will take what's a negative aspect of care, such as the uncertainty over a particular therapy, and turn it around into a positive thing. We will systematically use serial trials to determine the optimal intervention. Again, this is all based on the patient's priorities, not just their diseases. Before we describe the rationale and use of the three strategies, it's helpful to note that they're not meant to be sequential. They're not mutually exclusive. You are going to use some of them some of the time in different combinations, but they are the ones that we have found logically help us translate patients' priorities into the decision-making process. We are only able to briefly introduce the strategies here. We have an online patient priorities decisional guidance tool at patientprioritiescare.org that goes into greater depth to help you develop skills when engaging in patient priorities aligned decision-making with your patients. The tips and scripts in the online tool address strategies and troubleshooting of common scenarios that come up during decision-making for patients with multiple chronic conditions. Here is a link to the decisional guidance tool. It would be helpful for you to open up to the appropriate strategy to answer the questions throughout this case scenario. This will help you get started with using the tips and scripts during your encounters with patients. Let's go through the strategies with Mrs. B. The first is to use her priorities as a focus of communication and decision-making. There are several reasons this is important to do. Patients feel listened to and may be motivated to adhere to recommendations that link to what's most important to them. Each patient's own priorities give clinicians an anchor for decision-making in the face of uncertainty, complexity, and trade-offs. This is a way to decide if a treatment is effective. Did it really help them achieve their own particular outcome goals? So there's many reasons to focus on patients' priorities. So when you think about Mrs. B, there are many places to start. You now know what she is willing and able to do and what she felt was most burdensome. Let's start with her diuretic. You might say, "I know that torsemide is difficult because you have to go to the bathroom a lot, but if you'd be willing to cut back on some salt, you might be able to decrease the dose of the diuretic. It is important to keep fluid off your body so that you can be less short of breath to help you to do the things you want to do with your grandchildren." You thus present the trade-off, but the decision-making is within her priorities. Now it's your turn. Think about her priorities. What are some of the other ways you might think about communication and decision-making using her priorities? Please pause the recording at this time and review her history and priorities template to determine how you might use her priorities in communication and decision-making. You can also link to the Patient Priorities Decisional Guidance tool for searching additional ideas. Maybe you thought about the fact that one of her priorities is to have energy to watch your grandchildren after school. You might say, we know that when people use their CPAP for at least 4 hours a night, one benefit is usually more energy during the day, so you can focus on your grandchildren if you can find a way to use that device. Another example might be that she mentioned she wanted to avoid being in the hospital. You could link back to that preference to encourage her to use her diuretic to avoid going to the hospital. There are many other examples you might come up with. When you connect recommendations to what is meaningful to the patient, you strengthen the relationship and the partnership and increase the likelihood of adherence to the recommended treatment. Thank you. I now turn over the presentation to Dr. Claire Davenport, a medical geriatrician at Mount Sinai in New York City.
There is so much going on when there are multiple diseases, along with all the potential interventions and treatments that we can give for each of these individual diseases and conditions. It can seem overwhelming for the patient and for you, but it also brings to light the fact that there are different things that you can try. We've made that challenge one of our strategies. Exploring different interventions is a way to address the fact that there is no one right answer. If one thing doesn't work, there's always something else that we can try. Rather than an unfocused random approach, we'll use serial trials guided by the patient's priorities. We found it helpful to acknowledge from the beginning that we're not sure what's going to work best. For example, knowing what matters most to you and what healthcare tasks you're willing and able to do. These are the things I suggest that we try, but there's other things we can try next. In this way, we turn uncertainty and no right answer into a positive and offer patients hope, a sense of direction, and empowerment in their healthcare. Combining the first two strategies, we use the patient's priorities as a guide to starting, stopping, and continuing interventions. In Mrs. B's case, she wants to be able to volunteer at the library, putting books away, and to take care of her grandchildren. We also know about the care that she's willing and able to do. Knowing how she feels about different care helps us narrow the many things we can do by offering possibilities consistent with what she's willing and able to do. Her fatigue was the one thing that mattered to her, because it was keeping her from taking care of the grandchildren. One of the ways that we get started is with the one thing. This came out of an aha moment when we were developing patient priorities care. Even with the template, patients have 2 or 3 health outcome goals, 3 or 4 different healthcare tasks that they didn't mind doing, 3 or 4 that they didn't like, and some medications they like. There was still too much going on. This led us to focus on identifying what the patient felt was the most bothersome symptom or health problem that was keeping them from their most desired health outcome goal or activity. We start with the one thing. For Mrs. B, the one thing she wanted to focus on was being less tired so that she can watch her grandchildren. One of the serial trials we suggest here is retrying something she felt was burdensome, her CPAP machine. You might say to her, I know you don't like the CPAP, but I really think it's going to help you. Are you willing to try it again to see if it helps you reach your goal? We will judge how well the CPAP is working by your ability to play with your grandchildren and to volunteer at the library. We can then decide if any increased benefit is worth the burden. What do you think about that? There were several other options we could start with. If you think about what mattered most to her, which was to be less tired so that she could be with her grandchildren, where might you start in terms of her diseases or her treatments? Pause the recording and review her history and health priorities template to determine your responses. You can also link to the Patient Priorities Decisional Guidance tool to search for ideas. Perhaps you recalled her preference to take fewer medications. You said that you have been taking a lot of medications, which you find burdensome. Some were more manageable than others. You mentioned wanting to feel less tired so that you could be active with your grandchildren. We can take a look at some of your medications and perhaps decrease one that may be contributing to your fatigue. One that comes to mind is metoprolol. But there's a trade-off. This medicine helps to slow down your heart rate so that your atrial fibrillation doesn't go too fast. We would need to balance your heart rate while focusing on helping you feel less tired. We will judge how well it is working by your ability to play with your grandchildren and to volunteer at the library. What do you think about that? If your patient likes the idea of choosing where to begin their trials, you could suggest either the medication or the CPAP trial as a good starting point. One caveat is not to offer too many things at once, which could be overwhelming. We encounter some patients who are clear in their health outcome goals, but for various reasons do not accept or adhere to the interventions that are most likely to help them achieve these goals. In essence, the patient's healthcare preferences may interfere with achieving a health outcome goal. When this situation arises, first check for understanding by clarifying what the patient finds burdensome, difficult, or unpleasant to do. Clarify that this healthcare activity or therapy may help her achieve a stated health outcome goal. Here are some of the approaches to conversations when the patient's goals are not likely achievable. You can imagine having this sort of conversation with Mrs. B regarding her use of the CPAP after trials of reducing medications didn't help enough. You told me that you can't help with your grandchildren because you're too tired. We stopped a couple of your medications to see if that helped, but you're still too tired. I know you don't like the CPAP, but I'm concerned sleep apnea is the reason you are tired. Would you be willing to try the new CPAP mask for 1 week to see if you're rested enough to help with your grandchildren? If there's a resistance or hesitancy, you might explore further. Ask why the patient finds this treatment burdensome. Can you tell me what you find difficult or bothersome about the CPAP? It's also important to acknowledge the burden. I know the CPAP can be uncomfortable or difficult to wear each night. If ultimately your patient remains unwilling, acknowledge that and continue working on other issues. You can reintroduce it later. I worry we may not achieve your goal. I wonder if there are other ways to fulfill your value of spending time with your grandchildren that could be more achievable. You can also see troubleshooting in the Patient Priorities Decisional Guidance tool. Here are some additional strategies you might have thought of: a trial of antidepressant, progressive exercise program, or even referral for cardiac resynchronization therapy, if her ejection fraction qualifies her for this. There is no one right answer. We talked earlier about conflicting recommendations, often resulting from clinicians considering different information, different diseases, or different outcomes in their decision-making. Some clinicians feel particular guidelines apply, others don't. Guidelines for one condition may conflict with guidelines for another. One clinician may feel the patient's preference overrides the guidelines. With all of these possibilities, it's no wonder patients get conflicting messages from their various clinicians in primary and specialty care. How can we align decision-making when the clinicians don't always agree? When clinicians don't agree, it's most often because one clinician feels it's important to follow a particular guideline, and the other clinician may not feel that that guideline applies to this patient, or that the likelihood of benefit does not outweigh the likelihood of harm or burden. That clinician might be concerned that we're asking the patient to do something that they either do not want to do or are unable to do. Here are the steps that we found in our work with primary care clinicians and cardiologists. It is based on collaborative negotiation, often used in business when maintaining a relationship is important, but colleagues disagree on a specific plan. Acknowledge uncertainty and that there is often no one best answer. Identify and reconcile sources of differing recommendations. Decide based on patient priorities, not just disease-based trade-offs. Brainstorm alternatives until you arrive at a compromise or solution. The cardiologist felt strongly that beta blockers are guideline recommended and one of the most effective treatments, potentially for survival, and she also wanted to try to prevent progression of heart disease. The primary care provider really felt that the metoprolol was one of the things causing the fatigue and preventing her from enjoying time with her grandchildren. So they came up with opposite suggestions to Mrs. B. The conversation is around agreeing on the information that should inform the decision for this patient. In Mrs. B's case, it's about likely benefit and trade-offs and her own priorities. In terms of likely benefit, we often don't know the absolute benefit. Even when there's strong evidence, the evidence was not evaluated in people with 10 different conditions. These other conditions affect health, function, and longevity, and even the response to each treatment. We first acknowledge that uncertainty may arise from the different perspectives and sources of information that clinicians may have. In Mrs. B's case, her PCP thinks that the fatigue is likely from her metoprolol and wants to stop it. Her cardiologist feels the metoprolol is important to her long-term survival. A good place to start is a dialogue that can be written or spoken as time allows between clinicians. Mrs. B, one of our shared patients' main concerns, is her fatigue, which is keeping her from doing activities that matter to her. While there are several possible explanations, as a first step, I think we should stop her metoprolol. Its main benefit is survival, which is not her main priority. What are your thoughts? This slide presents a possible short conversation to help reconcile differing perspectives using a patient's priorities as a guide for collaborative decision-making. The PCP and cardiologist work towards a compromise. I'm concerned about stopping metoprolol. It took me several months to titrate to that dose. Her heart failure is severe, and beta blockers are one of the best ways to prevent progression. I know, but she felt better without the medication. Did you explain that this decision may shorten her life? I did. She said she'd just rather feel better today so she can watch her grandchildren. I wonder if she would agree to restart a low dose. If she notices the fatigue worsening again, we can stop it altogether. That sounds like a good compromise. What are some other possible conflicts that you can think of for a patient like Mrs. B? Pause and review her story and health priorities template and write down some of the answers. In the last section, we presented troubleshooting scenarios when the patient's goals are not realistic or achievable for different reasons. There's more on these troubleshooting scenarios in the Patient Priorities Care Decisional Guidance tool.